Welcome. We are glad to have you here with us for a virtual 2021 HEAL Association Conference presentation. My name is Andrea Martin, Hospital Education Manager at Veritas Collaborative's Atlanta, Georgia Hospital, and I'm here with Katherine Toman Brinkley, Education and Vocation Coordinator at Veritas Collaborative's Richmond, Virginia Center, and we are presenting Mental, Medical, and Multiple Diagnoses, a look into the individualized academic and transition plans for common comorbid diagnoses. We hope you enjoy this look into how Veritas Collaborative individualizes academic plans and transition plans for our patients. Let's get started.
Here at Veritas Collaborative, our mission and vision guide our team efforts to provide the best care to each family and individual we admit. Our mission reminds us of our passion for excellence. Our mission is driving the standard of care in eating disorders treatment through a collaborative community so that individuals and families can thrive. Our vision keeps us focused as we encounter new challenges. Our vision is a world in which all persons with eating disorders and their families have access to best practice care and hold hope for a cure. Our core values and dedication to increasing the access of care continues to drive our development of academic programs and educational support for all of our patients.
Here is some quick background information about our hospital and center locations. At Veritas Collaborative, we offer a full range of levels of care for eating disorder treatment. Our hospitals and centers house inpatient and residential programs, partial hospitalization programs, commonly known as a day program, an intensive outpatient program, outpatient providers, and an assessment clinic where eating disorder testing and diagnosis can occur with input from a multidisciplinary team. All of our locations serve all genders, gender identities, and gender expressions. Some of our locations serve different age groups, but system-wide, we serve patients of every age.
Each diagnosis has its own criteria, and many vary in the symptoms, behaviors, and motivations for such behaviors. A commonly known eating disorder diagnosis is anorexia nervosa. This disease is characterized by the inability to consume adequate nutrition, which leads to a low body weight or the failure to meet growth projections in children and young adults. Patients with anorexia nervosa have an intense fear of food and weight gain that is coupled with a disturbance of their body perception and a lack of body acceptance. Another commonly known diagnosis is bulimia nervosa. This disease is characterized by binge eating behaviors followed by purging episodes such as vomiting, the abuse of laxatives or diuretics, or a non-purging compensatory behavior such as extreme or intense exercise. Patients with bulimia nervosa tend to evaluate their bodies with unreasonably harsh standards that often involve around body shape or weight. A lesser-known diagnosis is binge eating disorder. This diagnosis is characterized by binge eating episodes that are followed by marked distress. Before treatment, many patients may not fully understand the triggers for their binge eating episodes and suffer from shame and intense emotional frustration. With this diagnosis, there is a distinct absence of purging or compensatory behaviors after purging episodes. Body weight, shape, or size are not criterion used in diagnosing binge eating disorder. Another lesser-known eating disorder is avoidant restrictive food intake disorder, or ARFID. This disease is characterized by a failure to meet nutritional or energy needs due to eating or feeding disturbances. This disorder is associated with weight loss, nutritional deficiencies, or the failure to meet growth projections. Food avoidance can be due to a fear of textures, colors, and tastes of food, or an extreme disgust for most foods, leading to an extremely limited diet and a lack of proper nutrition. We see this diagnosis most often in younger children or in those who have had feeding issues due to a previous medical treatment or procedure. They are now fearful of becoming sick, being in physical pain, or being disgusted by foods they once enjoyed. The last two eating disorders are used as diagnostic tools for atypical behaviors and motivations. The first is called Otherwise Specified Feeding or Eating Disorder, or OSFED. This disease is characterized by an atypical anorexia nervosa, bulimia nervosa, or a purging disorder that does not fit the criteria for the other diagnoses. The binge episodes may be low in frequency or duration in these patients. Lastly, unspecified feeding and eating disorder is used by healthcare providers while evaluating new patients or in emergency room admission situations. Healthcare professionals may notice marked symptoms of feeding or an eating disorder that do not meet all the criteria for a full diagnosis. Furthermore, medical providers may lack enough information at the time to make a full diagnosis or may feel that more investigation is needed by a permanent provider before diagnosing a patient. Each one of these disorders can affect our patients in extreme ways, physically, cognitively, and emotionally. The whole team approach to treating eating disorders allows providers, families, and patients to reach successful recovery more often and with a lower rate of relapse. This team normally includes a combination of medical doctors, pediatricians, family medicine practitioners, and hospitalists, as well as psychiatrists and psychiatric nurse practitioners. Specialized psychiatric and medical nursing staff members work with psychotherapists, registered dietitians, and nutrition specialists. Certified teachers, education coordinators, education and vocation coordinators collaborate with the clinical team throughout the entire treatment process. The intake and case managers also support our patients through the entire admission process at all sites. Therapeutic assistants, culinary staff, and art, yoga, and music therapists are also crucial members of the treatment team. Each patient has a variety of specialists who focus on each part of the patient's life and unique needs in order to address all concerns and diagnoses.
Eating disorders affect the entire body and can have severe medical and physical consequences. Some common complications include dehydration, electrolyte imbalances, and vitamin deficiencies, which can all add to depression, anxiety, worsening nausea symptoms, and at worst, severe heart issues such as tachycardia, bradycardia, arrhythmias, and other life-threatening symptoms. Patients with eating disorders often experience syncopal episodes or passing out due to hyper or hypoglycemia. They may also face heart issues and severe liver and kidney damage, each of which have no outward symptoms but can be life-threatening. Our female patients may also experience amenorrhea, which is a loss or delay of their menstrual cycle. In addition, loss of bone density can become irreversible after youth, so it needs to be addressed immediately. And the ultimate challenge for our patients with eating disorders is the nausea cycle. Patients will not eat. Because they do not eat, they experience nausea, which makes it more difficult for them to eat. This is a vicious cycle of symptoms that is debilitating for some patients who are also experiencing other GI-related issues listed here. In addition to the physical consequences of eating disorders, there are many cognitive effects. Malnourished and underweight patients lose cognitive function, have an inability to focus on or retain new information, have slower processing speeds, and even short-term memory impairment. Irritability, frustration, confusion, temperature regulation difficulties, dizziness, and sleep disturbances all make education a more than difficult task for a patient with an eating disorder. The largest cognitive and physical consequence we see is fatigue. Patients' bodies are simply too undernourished to function properly and fully in an academic setting, and patients need ample rest to aid their recovery process. These cognitive effects may not improve until full weight restoration and can return as fast or as slow as 3 months to 3 years after full weight restoration and maintenance.
Many patients present with more than one diagnosis, and treating the primary concern is more successful when supports and accommodations are made to help treat and mitigate the symptoms of the secondary diagnoses. Some of the most common comorbid diagnoses we encounter are attention deficit disorder and attention deficit hyperactive disorder, ADD and ADHD, obsessive compulsive disorder, OCD, major depressive disorder, MDD, generalized anxiety disorder, GAD, bipolar 1 and bipolar 2 disorder, BPD, borderline personality disorder, BPD, autism spectrum disorders, ASD, various learning disabilities, LD, and traumatic brain injuries, or TBIs. Please note that each patient may present with more than one of these secondary diagnoses. Each one must be managed through proper supports and accommodations for the treatment of the primary diagnosis to be successful. These comorbidities play a significant role during treatment. We will be exploring how we, as hospital educators and academic liaisons, can support our patients with these comorbidities during treatment so that they may reach a life in recovery.
As a hospital, we are able to offer comprehensive medical supports for patients with eating disorders and comorbid diagnoses. One medical support we offer is a feeding tube. At Veritas Collaborative, we believe food is just as important as medicine in eating disorder recovery, and some patients need assistance in restoring their weight to an ideal range. From personal experience at Veritas, I can attest to seeing cognitive function return when patients are around 80% of their estimated ideal body weight, and increasing cognitive function significantly when patients are weight restored or at their estimated ideal body weight. Another important piece of recovery is rest. As many of our patients are quite fatigued, all of our patients have scheduled rest times throughout the day. Depending on each individual's medical needs, our staff offers skin checks to identify self-harm, wound care, and falls risk assessments and protocols, since many of our patients are weakened and at risk of fainting. We also monitor and restrict patient access to sharp items or items that could be looped into a self-harm tool. We monitor bathroom usage to prevent purging, self-harm, and other compensatory eating disorder behaviors based on each individual's needs. Our medical staff meet with patients anywhere from daily to monthly, depending on their level of care, and we offer medication education to all patients. When patients admit to our facilities, we create an individualized academic plan for them. We use our education expertise to guide us, as well as important documentation from a patient's school, such as an IEP or 504 document. We assess each patient's school needs, and in conjunction with the multidisciplinary team Katherine detailed earlier in the presentation, we work with patient, parent, and school to obtain a reduced course load of schoolwork for the patient. Our education team updates this academic plan often throughout treatment and communicates these changes and updates with all team members, including patient, parent, and school, weekly. Our education staff also consists of special education teachers. When our patients have special needs that will affect their treatment, our special education staff communicate those needs to the treatment team and work with the team to accommodate the patient so they can be successful in treatment. We have a few case studies at the end of our presentation where you'll see more details about how we have accommodated different patients with different needs.
As a team, we provide guidance to providers on how best to communicate, support, and guide patients in completing all types of assignments. We also note our observations so that providers can be even more successful in communicating with each patient. For ADD, ADHD, OCD, and ASD diagnoses, we find several classroom, curriculum, and academic supports helpful for our patients in order to complete required tasks in the classroom and during groups. These may include a selectively designed assignment schedule based on each patient's current ability to complete tasks, and we may even offer multiple forms of expression for assignments in order to make the patient feel more comfortable and articulate. We may provide and create a select list of weekly and daily goals for class time to aid our patients in maintaining focus and directions, and by creating to-do lists or assignment priority lists, we allow room for small goal setting and for completion celebrations. We may also provide instrumental music for patients who prefer productive background noise in order to focus on the task at hand. Earbuds, noise-canceling headphones can be helpful in some cases as well. Frequent check-ins on work and goals also help each patient feel attended to and comfortable asking questions, as well as goal-oriented in the classroom. Lastly, individual point systems and behavior redirection plans guide each patient towards their treatment goals while helping them communicate academic assignments and practice positive behavior coping skills.
There are countless accommodations and ways to help individuals with comorbid diagnoses, so this is not an all-encompassing list, but rather a list of what we use most often with these particular diagnoses. For generalized anxiety disorder, major depressive disorder, borderline personality disorder, and bipolar disorders, we often find it helpful to break assignments down into smaller pieces and scaffold the work. When patients with these diagnoses see a thick packet of work, they do not rationalize out a plan. They immediately jump to negative conclusions and assume they can never finish all of that work on time, so why even try? By breaking the work down into small pieces, you give the patient several opportunities for success, and you reduce their anxiety by not allowing them to catastrophize about the amount of work they have to do. As you have all heard before, take it one day at a time. And we tell our patients, take it one assignment at a time, or even one small piece at a time. For these diagnoses, it is also helpful to explicitly create a plan with the patient around school expectations. Anxieties can rage when patients are not clear on expectations. So regular check-ins, constant positive reinforcement, and clearly communicated expectations will aid patients with these comorbid diagnoses immensely. Some patients may already have an organizational tool they use, but some patients may need help creating and implementing an organizational tool. We often scaffold this tool by starting with a simple daily to-do list with only 2 to 3 things on it, so they don't get overwhelmed. We will then increase the daily to-do list to either have more items or move to a weekly to-do list when the patient is comfortable. We then help the patient come up with their own plan for the day or week and help them continue to execute their own plan. Due to high anxieties associated with these comorbid diagnoses, it is advantageous to explicitly teach and reinforce therapy skills that patients are learning. At Veritas, we use a combination of DBT, dialectical behavioral therapy, and FBT, family-based therapy, and when patients are in distress, it will benefit them if you can point out and help patients work through some of their identified helpful coping strategies from therapy. Often, when patients are in distress, they are not able to access their therapy toolbox, and you can help them out and help them open that toolbox by suggesting coping skills or other therapeutic techniques that you know they are familiar with. Other important accommodations for these comorbid diagnoses include a low stimulus environment for school and extra time to complete assignments, assessments, and projects. For patients with specific learning disabilities or traumatic brain injuries, we offer many accommodations that are similar to those you would see in any school setting. Extra time, read aloud, and written and verbal directions are common helpful accommodations. We also offer our patients as many visual aids as possible. We will give them a modified schedule that has pictures with each task or group, and we even use plastic food models to help patients visualize correct food portions on different sized plates and bowls. For patients with these comorbid diagnoses, all aspects of treatment must be modified to meet the patient's cognitive level. So individual instruction on emotion vocabulary, medical vocabulary, and emotion regulation is extremely important. Our education staff will collaborate with any staff member to modify therapy, medical, or dietetic assignments, handouts, and lessons so that it's acceptable and accessible to the patient. And most importantly for patients with these comorbid diagnoses is consistency and repetition, repetition, repetition.
When it is time for a patient to step down to IOP evening care, we will work directly with their home schools to provide guidance, 504 and IEP recommendations, and documentation so that their school, the family, and the patient all feel comfortable with the patient returning to their school and environment. This includes a variety of planning and collaboration with school counseling and the school support staff. Some of our most common accommodations may include setting up a school day pass, which is considered a trial day for patients to practice attending school with their new accommodations and their new schedule. We routinely attend return to school meetings with school staff and parents to put accommodations and supports in place, often before the child study meeting has been completed and the 504 or IEP have been implemented. During the first week or two of the transition, we support school staff in creating new 504 and IEP plans for our students, and we do attend child study meetings whenever possible. We also provide documentation of completed work, appropriate accommodations, and attendance in groups and programming so that the school can adjust grades, schedules, and academic plans upon the student's return. Lastly, we routinely educate staff members and faculty on eating disorders and how they can best help a student in recovery. As we consider both the primary eating disorder diagnosis and the secondary mental health disorders that play a role in our patients' ability to complete tasks, we need to consider reasonable accommodations that make learning and adjusting to classroom environments manageable for our students. Some of the most common academic accommodations include a protected lunch without requests for makeup work or assessment completion, as well as a permanent pass to counseling that allows for check-ins for students for whom the classroom environment may become overwhelming. Furthermore, an alternate setting such as a classroom or counseling office space can provide a less stressful environment for lunch completion. In some cases, the extra support of a parent or guardian can also serve as a comfort for students. Our registered dietitian team recommends an allotted snack time for any testing session or class that lasts for more than 3 hours. Extended deadlines on projects, papers, and graded assessments with prior approval from the course teacher can reduce anxiety and stress of the graded assignment and the larger projects. A modified curriculum that does not include discussions of dieting, fitness, calories, or other healthy living topics, or the requirement of non-provider approved physical activity can minimize the anxiety or panic for a student who is adjusting to their classes after an extended absence. Permission to use their phone to take photos for their lunch before and after the meal can be a supportive tool for patients to communicate their needs with their team and their support system at home. In some cases, patients respond best to an abbreviated schedule that includes either leaving school early or arriving late, so they get the experience of being in classes without feeling too overwhelmed or exhausted by the stimuli in an entire school day. For visual learners, it is helpful to provide written class notes for all core classes and additional practice with printed study guides before tests. Additionally, extended time on graded timed assessments can help students focus on the material and their performance. Sensory items such as fidget spinners, stress balls, and thinking putty can support focus and positive coping skills for students feeling distressed, and the use of noise-canceling headphones or earbuds for individual work can reduce distractions and anxiety in the classroom. Daily teacher check-ins on planners and to-do lists are helpful for keeping the students on track while giving the teacher the ability to gauge the student's progress in class and privately. Also, pre-planned nonverbal cues between teachers and the student fosters attention, ends disruptive behavior, and reminds the students of their academic goals. Lastly, allowing students extended time to travel from classroom to classroom takes the pressure off a commonly busy, potentially chaotic transition period for students with sensory needs. There are creative ways to support our students, and collaboration with a full treatment team and support school staff can be helpful in determining what is best for the student and for the school.
Here we will discuss 3 unique cases of patients who had multiple comorbid diagnoses and what we were able to do to help these patients be successful in treatment. I will start with Alice. Alice is an 11-year-old girl diagnosed with anorexia nervosa. Alice is profoundly deaf and has a cochlear implant in one ear and a hearing aid in the other. However, Alice did not receive these implants until she was 6 years old, even though she could not hear from birth, meaning she did not begin to hear or learn to recognize sounds until she was 6. In addition, her parents are Spanish-speaking, but Alice has always attended English-speaking public schools in Georgia, so she is bilingual, speaking Spanish at home and English at school. Alice was taught minimal sign language at school, and her parents have no sign language knowledge, so her main form of communication is through speech and lip reading. Alice has been chronically malnourished her whole life and has trended on the lowest end of her growth curves. For Alice, a hospitalization would take away hours of daily instruction, speech therapy, and special education services. So we helped Alice by getting an FM transmitting device from her school. We could use this device to speak directly into her cochlear implant so she could hear us if we were not looking directly at her or if we were not near her. We instructed staff and patients on appropriate ways of communicating with Alice by facing her when you speak so she can read your lips, by standing close to her when you speak, speaking clearly, and always using the FM device, even in group settings by passing around the FM device so she could hear everyone. We gave Alice a visual schedule since her vocabulary was severely lacking. We also directly instructed Alice on vocabulary she would need to know in the hospital, such as common emotions, food terms, medical terms, and even age-appropriate slang her peers were using. We modified all of Alice's therapy, dietetic, and medical handouts and notes, and all of her academic education to include visuals and appropriate vocabulary that she could comprehend, and we used visual aids in any situation we could. For example, we have plastic play food we used to show Alice food portion sizes. We had an emotion wheel with her common emotions and pictures of what that emotion looks like on someone's face. We used simple sign language hand signals for communication with her for directions or common needs, such as bathroom time, I'm full, I am hungry, etc. And we used visual representations of academic concepts with manipulatives. So math manipulatives, blocks, counters, anything really we could have her put her hands on to help her learn the concepts.
Let's consider the case study of Bobby, a 15-year-old male with ARFID, OCD, bipolar disorder, ADHD, and generalized anxiety disorder. When he admitted to PHP, he was significantly malnourished, challenged by new and different foods, and had consistent outbursts and refusals anytime he felt uncomfortable or scared. He had notable difficulties with peer interactions, environmental and schedule changes, and struggled with reading social cues and communicating his needs to peers and staff alike. Academically, he had trouble beginning or completing tasks, staying on task, and retaining details and directions that were only verbal or only written. His strong desire to please teachers and his parents made his difficulties hard for him to process, and his fear of failure fueled his desire to avoid starting new assignments. In order to support his learning and success in peer groups, we used several modifications and accommodations that were later passed on to his school for an updated 504 plan. We created prioritized assignment lists and chunked his assignments in order to allow him to focus on smaller goals, while printed schedules and verbal alerts before unexpected schedule changes reduced his fear of change and failure. Organizational tools such as binders, dividers, and sticky notes for each subject, and extra time on tests and quizzes, and any graded assignment, gave him the ability to express his knowledge on important assessments and kept his thoughts clear and neat. To avoid mental fatigue, short breaks after 20 minutes of successful academic progress fostered a pattern of reasonable expectations for himself, his teachers, and for his parents. Also, noise-canceling headphones created a non-distracting environment for Bobby. Agreed upon nonverbal cues from staff members and a point system for completed work and positive coping behaviors increased his ability to use his coping skills positively and recognize success in class. Overall, these modifications changed his outlook on his academic abilities, gave Bobby the self-confidence and positive reinforcement he needed. They also guided his teachers and parents in appropriate measures to foster kind redirection and support as he developed his own skills.
Another unique case we have is Landon, a 10-year-old boy with several diagnoses. He has binge eating disorder, autism spectrum disorder, oppositional defiant disorder, and obsessive compulsive disorder. His story comes with many challenges. Medically, he had a colorectal tube that had to be used and cleaned multiple times per day when he used the bathroom. His bowel issues caused him severe pain, and he missed a large amount of time of treatment, groups, and school just using the bathroom. He also had behavior challenges as well. Landon is on the spectrum, and he has a very rigid schedule in his mind that he likes to stick to, so changes of the daily schedule were very difficult for him. He also had some anger and aggression with his ODD that could be enhanced by not being able to do some of his OCD rituals or by changes in his schedule. And Landon had learning challenges. Because he had been hospitalized so much, he has missed a large chunk of school during his formative years, leaving him quite behind and lacking those good foundational skills in math and reading. Landon also misses instruction or is not able to participate fully in school when his ODD and temper flare up, leaving him even further behind. At 10 years old and in 4th grade, Landon was reading on a 1st grade level and not able to perform basic arithmetic. Landon is a success story, though, because we quickly identified a behavior plan for him that included scheduled breaks throughout the day and a calm down space and plan for when he was feeling upset. We gave Landon a visual schedule on half a piece of paper with the other half open for sticky notes. So when his doctors or other providers needed to meet with him outside of his normal schedule, they could put a sticky note reminder on his schedule each morning so Landon would not be surprised and upset when they came to visit. We also did direct instruction with Landon on emotions and emotion regulation using various social stories and silly emotion charts with silly faces on them. He also needed direct instruction in every academic field. Most importantly, we had a positive behavior intervention system in place for Landon. We were consistent with rewards and consequences. We explicitly taught Landon the rules in a cognitively appropriate approach and praised his positive behaviors endlessly. This was the key to earning his trust and getting his buy-in to treatment and doing hard things he did not want to do while hospitalized.
Now that we have covered several techniques and possible modifications for common comorbidities, let us consider how you will use this information moving forward. You may ask yourself, which common comorbid diagnoses do you see most often in your hospital or treatment center? Begin to connect this new information with the diagnoses that are most relevant for your patient population. Secondly, are there systems in place to serve both the secondary diagnoses and the treatment of the primary medical or mental health concerns together? It may be helpful to explore how your team modifies and adapts to secondary diagnoses during the treatment of the primary concern. Lastly, are there parts of your treatment program that can accommodate the diagnoses we've discussed as they affect your patient's ability to learn effectively? In some cases, there may be gaps in support for the secondary comorbid diseases, and it may be beneficial to develop ways of incorporating some of the academic supports and transition plans we've covered here today.
I hope there are some takeaways from this presentation that you can implement at your own facility. If you have questions about eating disorders, this presentation, or just want to pick our brains for more ideas on how to help your patients, here's our contact information. Feel free to reach out to us. Thank you for viewing our presentation, and I wish you a happy virtual HEAL conference.